I'm Jedda. I work in a general practice down in Wollongong, and this is my first time coming to an APNA conference, and so my first time presenting at one. So I'm talking about the high risk diabetes assessment that we've started at our practice, and we'll crack into it. So as you would all know, diabetes is a really significant disease in Australia, and there's obviously many complications, as we've just heard about. In 2016, the level of diabetes prevalence in Australia was 5.1. That was in a self-reported study, and 85% of that number was type 2 diabetes. Type 2 diabetes can be preventable for a lot of people, and its incidence is increasing. So it's tripled in the last 20 years. Typically, type 2 diabetes is diagnosed, or the onset of age is about 45 years. I did read a study that was estimating it was about 57 was average age. That was a UK study. And with such big complications on all the different, so many different areas of life, cardiovascular, kidney, there's lots of complications and impacts and burdens on individual patients, their families, their finances, and the healthcare system. So it's a really important one. If we can prevent it, which we can, we should be really managing that. So again, this is just looking at the prevalence. So you can see that it significantly increases from the age of 45, and again more so from 55 onwards, which is where we sort of targeted our program. As I said, diabetes is largely preventable, type 2 diabetes, and the risk factors that we're looking at really work into the lifestyle modification or lifestyle behaviours. If we can modify a lot of those, then you reduce the risk of developing diabetes. So the risk factors that the RACGP or the Royal College of General Practitioners identify is the impaired glucose tolerance, or the impaired fasting glucose. Anyone with a history of PCOS, gestational diabetes, anyone on antipsychotic medications, anyone with a cardiovascular history. And interestingly, which is where this program sort of led to as well, was anyone aged over 40 with a BMI of over 30, or anyone aged over 30 with hypertension. And there's also, we focus less in our program, but anyone aged over 35 from the Pacific Islands, Indian subcontinent, or China, also at high risk as well as Aboriginal and Torres Strait Islanders over 18. So, reducing or focusing on lifestyle modification significantly reduces diabetes complications, their risk. It prevents, so it can prevent it, but can also delay the age of onset, which is really important. Early diagnosis leads to a reduced amount of later complications, which is quite important for, again, our individual patients as well as our healthcare system. And it works quite well with the kidney presentation, but hypertension is a really significant risk factor for diabetes as well as kidney disease. And you can just, what I've got up here is the more common presentations for GPs throughout life ages, or life ages. So over 45, hypertension for both men and women is one of the most common reasons for GP visits. So all of those people are at high risk of both kidney disease and diabetes, which means we should be trying to identify and manage this risk. Just on blood pressure, as we've talked about, hypertension is a really significant issue with really significant impacts. There's a really good study happening if you're a New South Wales practice nurse with Catherine Stevens down at the Uni of Wollongong. She's doing a nurse-led intervention, so seeing how nurses manage hypertension in general practice. The pilot study went really well, and they found that it was quite acceptable for patients, and that it was really effective, and they found that it was a drop of 14 milligrams in blood pressure just from the nurse-led intervention. So she's in here at the moment. She's got a few flyers. Let us know if you want to be part of that. It looks very exciting. Back to this one. Currently, there's a few ways that we're screening people. It's largely opportunistic apart from these funded health assessments that the government does. Medicare funds a single health assessment for people aged between 45 and 49, and that's just a one-off assessment. That's the item numbers up there, the 703, 75, 707. They also fund they fund a 3-yearly assessment for people aged 40 to 49 who have been identified as high risk of diabetes. That does depend though on whether they're attending a surgery often enough to be picked up on, and it relies then on people getting blood pressures and heights and weights to be able to identify that. But that is a good program in the 40s, but then it's only until 49. For Aboriginal and Torres Strait Islander peoples, they're able to have a health assessment annually, as are people over 75. But that does mean that people between the age of 50 and 74 aren't eligible for any routine or structured health assessments, even if previously they were identified as high risk for diabetes. So we decided we would have a look at it at our practice. Our goal was to have a program that was financially viable, was acceptable for patients, and they would actually come in and engage with us, and effective at preventing diabetes, or at least managing those risk factors. So obviously we had to identify the patients that were at high risk of diabetes. We used that RACGP risk factor model, and using clinical our data software, so best practice, we identified 948 patients in that age bracket. I think what we would probably do now is use PenCat if we had it, but certainly using whatever practice software you have, they should have a search component on it. And then we started offering these appointments to people. So initially it was me calling up individuals and having a chat. When we realised that people were interested and they were willing to do it, we started sending out a few letters and some emails, and then getting reception on board. They would come in for the assessments, and then we'd arrange follow-up appointments afterwards, either with a nurse or the GP. So the actual appointment, once we'd got our people in, we went through pretty much, I like to think of it as OBS, a SNAP assessment, an ECG and ABI. So height and weight, which give us our BMI, waist circumference, blood pressure and blood glucose level. It does just say BG, sorry. They're really important because you can then get that trend of, is someone actually still at risk with just their BMI, or is their blood pressure being managed well? So then identifying it and discussing with that patient what their individual risk factors are. I think that's probably the main part of that. The program is really the patient education and going, what do you understand your lifestyle risk factors to be? Do you realise that there are actually risks with where you are at the moment? And then how do you want to sort of manage that? Which is, we use the SNAP lifestyle advice as well, so going through smoking, nutrition, alcohol and physical activity. Obviously it's hard for patients to tackle all of those at once if they're all complicated and things for those people. So trying to go through then and find out what those particular patients want to focus on, where they really think they could have effective change, and then trying to make some realistic goals with them that are appropriate and achievable. Again, we would do pathology, just like with the kidney health. We're trying to include that in there as well, actually. So this program kind of blew out over the year. So now we do ACRs as well. Then we go and do the ECG and ABI to give us a really good baseline for clinical information. Just thinking of the pathology, HBO&C, a lot of people didn't and don't have that, and they haven't had recent pathology, particularly in that age bracket. So that's really useful information to have, even as just a monitoring thing. And then after the ECG and ABI, we do just plan the follow-up. The ECG and ABI are the reason that we can do this, because they make it financially viable. There are item numbers for it, which means that we're able to get really good clinical information, but also we're able to run this as a bulk billed appointment. The ECGs and ABIs obviously are looking at cardiovascular risk as well. We thought that was quite justified to look at, given that sort of 75 to 80% of people with diabetes or type 2 diabetes die of cardiovascular disease. And having diabetes type 2 increases your risk of having coronary heart disease by up to 4%. So having good baseline data early on is much better for these people, as well as meaning that we can actually do these in practice as well. Looking at planning follow-up, it really depended on the person as well. We would get our GPs to review the ABI and the ECG on the day, and then possibly think about a GP management plan if it was appropriate, or if they didn't already have one. A lot of people did, and we'd just be adding to that. And then we were able to arrange a follow-up using the 10997 nurse numbers. But again, the follow-up really depended on the person. There was a few people that wanted to come back within a month or every few weeks, just to really get a start on their lifestyle change. Other people wanted to give it 3 or 6 months to let them introduce the change and then see a measurable change in their own lives as well. So, outcomes. So, when I was getting this already, we were looking from January to January. So, January last year to January this year, we saw 240 patients. I think when I checked last week, we'd done about 310, 320. And just looking at financial viability, I didn't include GP management plans because it's too difficult to figure out what's new and what's not, and what's related. So without care plans, we billed about $24,324, which roughly turns out to about $100 a patient. So 213 ECGs, 219 ABIs. If someone had done an ECG with a pathologist or with us or with a specialist, we wouldn't do it because we don't want to be, it's not clinically appropriate to repeat data for the sake of it, or resource effective. The billing, so the bulk billed, 3s or 23s depending on the GP involvement. And a lot of the people that are actually at high risk are eligible for that's a chronic disease that they have already, so PCOS, things like that. So they're able to have potentially GP management plans depending on their doctor. Yeah, though I suppose the big thing is how do you make it accessible for someone to make lifestyle changes, and does that mean we need to be looking at ways of opening up access to dietitians or to exercise physiologists, and that's where they are very helpful. And again, bringing people back if they did have a care plan, and being able to use the nurse item numbers to fund that as well. So apart from the finance side of things, what I was more excited about is these outcomes. We found there was a lot more patients engaging us. These people are most people were pretty happy to come and have a chat about preventing disease. So increased engagement and patient education were really important. Often quite a number of these patients hadn't actually seen the doctor in sort of up to 3 years, and when I was calling them, it was going, are you still coming to this practice, or are you not here? And they just had got busy with life, didn't want to come in when they weren't sick. So it was really good to be able to go, we're a health service that is here for prevention as well as acute. And then again, the patient education of going, your lifestyle risk factors, where are they with you? What do you want to do to change things and improve things? That's really helped with our nurse role and our nurse recognition of what practice nurses can do. Definitely for the patients, I feel that they now go, a practice nurse is someone that you can go to and talk about your blood pressure, or talk to about diet. It doesn't have to be something that's wrong necessarily, just something that you want support with. And again, recognition of the nurse role in a preventative scope in the clinical team. So a lot of our GPs have been, I suppose, surprised that the nurses can have such a big role and influence in preventative health in that team as well. Certainly, we've seen improvements in patients' lifestyles and their lifestyle choices and their awareness of how they impact, and their achievements of goals that we've been able to make and support with them. And we found that our nurses, as a nursing team, we've definitely increased our education in lifestyle identification of risk, and how to help people modify it and feel empowered to actually change and achieve goals. Our practice has seen the benefit in educating us in lifestyle interventions, and as we've heard with many of the other presentations, that's really hard to get a practice to see the benefit in that, and then get the training in there as well. And as we do it more and more, we find we're more confident in delivering that as well, and working with patients to achieve their individual goals to improve their health. We've also found that as a nursing team, there's been increased referrals to allied health, to dietitians, to exercise physios, as well as to local groups. So we're, as a nursing team, I think keeping our eyes and ears out for exercise groups, support groups that can be good options for our patients, to give them ideas of how to change as well. And again, we found quite a few detections of abnormal ECGs and ABIs, and it's good to be able to detect them early to prevent the complications from happening. With the wisdom of retrospect, we would have done this study slightly differently. We didn't really run it as a study, it was more of a practical program to see if it would work. But if we did it again, I think I'd probably try and do some sort of better evaluation of measures, because it's been really hard to track the lifestyle impacts. So if you were to do this, maybe do a survey or something, or monitor your people a bit better than we did. It's hard when you know that there's change, you just can't prove it with the numbers. So we've found that this nurse-led clinic or intervention or appointment has been really useful for our patients and our practice and our nursing team. It's also flowed over onto the other ways that our nurses are used within the practice. Chronic disease management is now much more nurse-led. We have diabetes and heart or cardiovascular patients that now just see the nurses, and then we'll see the doctors later on, and that the doctors are much more comfortable that we're able to deliver good information and assessment of our patients. And what we're hoping to see, and to continue to see, is a reduction in the diagnosis of new diabetes as we prevent it, or an increased earlier identification of diabetes and diagnosis of it. They're my little references. Yeah, thank you for listening.